All right. Hi, everyone. My name is Yasmin. I'm the Community Engagement Coordinator for OIUF. If you guys haven't been to our support group meetings in the past, here's just a little introduction to our organization. And we're essentially a nonprofit organization, and our mission is to help patients and caregivers who are suffering from ocular inflammatory diseases like uveitis or scleritis, in addition to providing education and training to both patients and physicians that would be treating this condition. And in addition to our support groups, which we hold virtually once a month, we have some upcoming events that, in case anyone's interested in connecting with our community, we have educational events. We have our Crash Course Conference, which is a conference that we do once a year for patients, physicians, and caregivers to have a sort of crash course into the understanding of ocular inflammatory diseases. And in terms of fundraising events, we have our online auction that will be happening in November, in addition to our Walks for Vision, both in Boston and New Jersey, towards the end of the summer. All right, and I'm going to hand it over to our support group chair facilitator, Frances Foster, who's going to introduce today's session.
Hello, everybody. Welcome to our Uveitis Ocular Inflammatory Disease Support Group. I'm a little under the weather, so I apologize for my voice, but that's the good part of Zoom because we can still hold a meeting and nobody gets sick. So I just want to go over some of the ground rules for the support group, define the support group. So our uveitis and ocular inflammatory disease support group is a self-help support group. We are here to share our stories and experiences to help each other move forward with living and coping better with a chronic eye inflammatory disease, and to ensure that we are all getting the most appropriate care. The ground rules for the meeting are that we're here again to focus on the present, to learn to cope the best we can with our chronic illness. We don't offer medical advice unless we have a license to do so. We don't criticize healthcare providers or past healthcare experiences. We are not here to diagnose and treat, and no one is to ask a guest lecturer to diagnose or treat them. I'd like everybody to stay muted until it's your turn to speak. That decreases the echoing. And if we get Zoom bombed, everybody leaves the meeting and rejoins the meeting. With that said, I'd like to introduce our speaker this evening. So our talk this evening is Navigating Life with Low Vision. And we have the wonderful Dr. Elliot Feldman, who is the founder and managing director of Visions of Independence, who will be speaking to us tonight. After the talk, we will open it up to discussion. You can use the chat during the talk, but we won't address anything until after the talk is over. So Dr. Feldman, as I said, is the founder and managing director of Visions of Independence. He has been recognized as a national expert on elder care and programs to help older visually impaired patients. He was formerly the Chief Executive Officer and Executive Director of Greater Boston Aid to the Blind. He has had over 30 years of experience in meeting the needs of older patients with low vision. And he is also the founder of Visions of Independence, specifically to meet the needs of this growing and underserved population. And we're very honored to have him here to speak with us tonight. And I will turn over the screen share, Yasmin, to Dr. Feldman. I said Friedman, I apologize.
It's all right, but also I'm not a doctor, I have to confess, so.
Okay, well, I gave you another degree.
No, it's okay. I don't want to misrepresent here, okay?
Okay.
There we go. Slideshow, I think. From beginning. This works. Okay. Does everyone see it?
Yep.
Cool. First off, it's an honor for me to be here to speak to the group. We think support groups are incredibly important for two reasons. One is because it's good to share knowledge, it's good to share feelings in terms of support groups, but the other reason is it's a good opportunity. Many support groups actually have outside speakers that speak, and it's a great opportunity to learn about new programs, new resources, et cetera. So, you know, kudos to the foundation for having a support group about this stuff. It's only an upside. And I want to commend any of you people who have low vision in terms of participating in support groups, because I think it takes some courage to come out and to say, yeah, I'm having some vision loss and things are harder than they used to be. You know, when I'm outside speaking, it's like probably 3 times as many people should be listening, and that because they're visually impaired, but they don't have the courage to go out and to say that. So kudos to all of you for that. So this is a real answer. So Francis and Yasmin, if somehow or other they maybe in the chat could communicate, would be good. Okay.
Okay, yeah, everybody can answer in the chat and we'll monitor that.
So the bottom one actually should be more yellow than it is, but so just pretend it's yellow. But you can see, so it's black and white, and then it's black on some colored background. So the question is, everybody, which text do you see better? Black on white, or you can say the other. So I'm not catching the score, so I could use your help, Francis, and yes.
So far, we have 1 for the yellow and 1 for the white, and I'd say they're equal to me. We have another for the yellow. We have another for the yellow. So we have 3 to the yellow, 1 to the white. Now they're about the same.
Right. Well, it's really not. Maybe I hope you guys are seeing it more yellow than I am. Are you seeing it yellow, Francis?
I see it yellow.
Oh, great, because my computer's not showing. Oh, it makes me feel a lot better. That's good. Well, this is one of the principles. And, you know, much of our world is black type on white paper. And so one of the things that we teach is contrast. And for the human eye, for many, many of our patients, at least, black on yellow is a better contrasting combination than black on white. The print kind of pops out better. So there's no wrong answer to this. You see what you see, whatever works. But so anything that we can do to enhance and increase the contrast is an important goal for us in terms of working with patients. And so let me see the moment. And Visions of Independence is kind of special and unique because we're an occupational therapy program who only works with people who've lost vision. I'm not going to sell the agency, but you know, we work with patients in their homes. Insurance covers us because we're occupational therapists. But the fundamental purpose for us is to increase the functionality of our patients, our low vision patients, whatever their cause is, whatever the reason is. Basically, we're very functionally driven. Tell us what you want to be doing easier, and we'll do our best to use some compensatory strategies to allow you to have an easier time to do that. So that's who we are in a nutshell. So a lot of stuff goes on with low vision, and we encounter this all the time with our patients. A study at least suggests that 34% of patients who who are visually impaired show some level of clinical depression. And there's a lot of reasons for that, some of which I'll actually get into in a second. But you know, there's a significant, as you all know better than I'm not visually impaired. There's a profound loss of independence. All of a sudden, things you used to do, you can't do. For many of our patients, for example, they can't drive anymore, which means at that point, they're dependent on other people to take them, even for the simplest sort of errand, you know, to the drugstore to pick this up, or for the cleaners or whatever. So you can, that's a taste in terms of why clinical depression's there. There's a significant risk to personal safety for our patients. You know, there is a direct correlation between low vision and falls, unfortunately. And there are some things that we try to do to try and minimize that possibility. But falls is definitely a risk for our patients, to the point of that 18% of hip fractures are vision related. And I'm going to show you a specific reason, one specific reason in a second. But like I said, hip fractures, vision loss is a big deal there. We have run into cuts and burns. Visions of Independence we are 20 years old this month. All right. And there have been 2 instances in the 20 years that our patients cut their thumbs instead of the carrots they thought they were cutting. Yes, I saw the grimace, Francis. I saw that. You know, so the statistics, I don't have the exact statistics about that, but they're there. You know, one of the benchmarks in terms of this stuff is that while wearing glasses, are people able to read a newspaper? Not without the glasses. I can't read a newspaper without my glasses, but while wearing glasses and so well, in general, in terms of the elder population, about 15% of people 65 and now older, 65 have some vision loss, and when that cohort of 85 and older, it gets to be 20 to 25%. So vision loss is age-related in our world. As I was telling Francis and Yasmin earlier, many of our patients have either diabetic retinopathy or they have macular degeneration, which is macular degeneration being age-related. So, you know, this is part of us too. You know, small changes make some big differences. You know, we can help our patients in vision rehab in general, not just, this isn't an ad for Visions of Independence. It's saying there are things that people can do to increase their independent safety, and in so doing would feel enhance their self-esteem. So what all vision rehab does is help patients use the vision that they have more effectively. And I was telling Francis and Yasmin before this that, you know, there are times ophthalmologists will say to a patient, "That's all I can do for you. There's nothing more I can do." And then when the referral comes to us, they say, "Well, how can you help us, me, when Dr. Jones says there's nothing more that he can do?" And the answer is, because we're not medical, we're rehab. We're going to teach different strategies. So these are activities for daily living and independent activities for daily living. You're going to see a list in a second. But basically, you know, life isn't, you know, 3 big things that we do all day. It's 8,000 little things that we do all day long. So we're very clear to tell our patients that we can't improve their vision. And we're very clear to say that after working with us, life's not going to be peachy keen, perfect, wonderful again, but it'll be better. And, you know, using compensatory strategies, you know, I have a kind of a saying that better is a heck of a lot better than not better. So even people with uveitis, you've lived your daily living skills when you had full vision. And when the vision loss happens, you have to, things change. And so it's a question, I go back to what I said, of being able to learn in different strategies to do what you were doing before. Most of our population, they had good vision when they were, you know, not just growing up, but well into their 50s, 60s. And so all of a sudden, you know, they're doing everything they did before, when in fact we would say, wait a second, here's some principles that you can use that might make things better and easier. And it's nothing very profound here. This is life. You know, I'm going to read it for those of you who can't read it. Medication management, personal care, cooking, cleaning, dressing, managing money, reading, writing, organizing living space, organizing phones, contacts. And I should add, in fact, I will after this, using cell phones, computers, you know, all the stuff that's there. It's part of life. There's nothing fancy here, you know, and the truth is this list could be, you know, 10 times as big as it is. But the point I'm trying to make is this is life. Everyday little things that we have to do all day long that we've done since we woke up this morning. So this is an example of one of our strategies. So for those of you who can't see it, this is basement stairs. And basically they're made of wood, and not even a light shade of wood, a medium shade of wood. And what I say to people is if you look down those stairs, what you're going to see, they kind of blend in together. Even for those people who have good vision, they kind of blend in together. And so what we do is we build one that's the black on the white, the black on yellow, if you recall, that was contrast. This is contrast too. So that you can see at the very bottom stair is that strip of yellow tape. We wanted to put a yellow tape on each stair, at the edge of each stair, which would, trust me, at that point would really pop out. But our patient didn't let us do that. And by the way, parenthetically, you know, inevitably people want to save a couple of bucks, so they put in a 40-watt light bulb in the fixture that's over the basement stairs. And that's not helping. Not helping at all. So another strategy is bigger is better, which is a couple of ways. One is adaptive equipment, and the other one's optical devices. So this is an example of an optical device. Some of you probably use handheld magnifiers, and you know there's an LED light that's in this magnifier. I think it's an Eschenbach magnifier, and you know you don't get this at CVS. You really have to either get it online or else. In fact, Francis, if you remind me, if we have a few minutes, I want to talk about low vision specialists, but we'll wait for that. All right. And these magnifiers, they go everywhere from 2 to 10 power. And in fact, you can see, for those who can, this is magnification levels up to 10, 5, 3, 2. And so this is print that they blow up, you know, with the level of magnification. And some people only need 2 or 3, and some people need 10. And if you need 10, you know, on the one hand, you are able to read, but on the other hand, takes a lot more effort and time. Whoops. I had a heavy hand. Give me a second. I want to go back there. I love this. Did it again. Wow. Sorry, people. Give me a second. I really want to show that thing. Okay. So much of what there is as probably some of you know, maybe all of you know, there's incredibly sophisticated electronic equipment that's out there that to do all kinds of things. We don't really talk about that kind of stuff because it's for many of our patients, it costs too much for them to be buying this. But there is much of the stuff that we would recommend in terms of adaptive equipment is fairly inexpensive and really good in terms of gifts for holidays, birthdays, whatever. I have a couple of favorites of that I'm going to show you. This is one of my favorites. So this is a bedside alarm clock, and the display is 3 inches tall. And it's a fluorescent orange, red sort of thing. And it's important for me, you know, if you're getting up in the middle of the night, you want to know, am I up for the day, or else, you know, can I go back to sleep? And this is a good way of doing it. And this one's only $18. So it can really, and it's got an alarm, it's got all kinds of stuff. But what's important here is the print is 3 inches display. 3 inches is a big print. You don't get most bedside alarm clocks that have that kind of height. And as I said, it's got the fluorescent numbers, so only $18. One of the tricks, this is a couple of things to say in this slide. One is back to contrast. So when I look, I believe white on black actually is a better contrasting combination than black on white. All right. I think these numbers really stand out. There is Braille on these numbers. Very few of our patients read Braille, though, because typically they lost some vision. They lost the vision as they got older. They already developed their literacy skills. You know, they know how to read in principle, they know how to spell, et cetera, et cetera. And so one of the things, if you were, when we were kids, I remember buttons. Remember the button candies? Used to peel them off and eat them, right? And so that's sort of what these are. These are called bump dots. What we have there in the 9 and the 1. They peel off and they come in fluorescent orange, white, or black. So what you do is you want to enhance use the right color bump dot for what the background is. So for example, you wouldn't put a white bump dot on a white, let's say phone key here, but you would put it on a black one. And you got the fluorescent one here. And so one of the things that we think is really important is teaching our patients, making sure rather that they have the ability to access emergency services. And sure enough, if you look at this, see what the numbers that are marked, and one is 9 and one is 1. So we felt pretty good about this gentleman being able to dial 911. And he liked this so much that he actually, this is a answer machine that he made us put the bump dot on the play button. And that's great, you know? I think it's great. So the different strategies, bigger is better, contrast, and lighting. Lighting is really important. It helps us all, even for people, if you think about it, even for people who are sighted or people who had more vision at some point, you know, if you have a garment in your hand and it's blue, or if it's dark blue, or if it's black, people typically bring it over to the window because it gives better light than the light overhead. Light overhead isn't so good in terms of helping functionality. Task lighting is good. Some people think that, that window light is good if that's what you want to do. And people do that all the time. Task lighting is not the overhead lighting. So it's the $20 desk lamp that you could get at Walmart or Target that you put. Here's another example that you put in strategic places. If in fact you all believe what I said, that most of our patients had good vision when they were younger, when I speak to people, I say, all right, everybody here, who has a desk lamp on your kitchen counter? And the answer is very few ever put their hands up. But when I explain that having a desk lamp on the kitchen counter can really, really help things because you can direct the light exactly to the surface you want, then people say, oh yeah, that makes sense. So for example, I hope nobody's eating here. When I talked about, that the thumb getting cut, that's a good example. So if you shine good light onto the cutting board, more likely than not, the patient would have saw, oh, that's not a carrot, that's my thumb, because the light is right there shining on the task. So we love $20 desk lamps. We think that having them strategically placed in the house is really important. Wherever you answer your phone, make sure you've got a yellow pad and a black felt tip marker and light. Wherever you open up your mail, wherever in the kitchen, the kitchen counter, make sure that you have a desk lamp there. Light makes a profound difference for most of our patients. And I'm not sure, I don't know anything about all of you that's on this call, but I'm pretty sure good light can really make a big difference. And just one example of that, though, is for you ladies who go around with purses, there are really good, small, compact flashlights. They'll cost you $10, and they can really, really make a difference because you could pull it out of your purse and shine it on whatever you want to do. It could be the menu, it could be a thermostat, it could be an oven setting, whatever. But the point is, that's the same example, the same principle. The direct light aims exactly where you want it to go. If any of you are crafty, there's a kind of light called the OTT lights. That is supposed to simulate the sunlight that we get through our windows. But they're expensive. They're like $90, $100 for a lamp. So my personal opinion is, if you have $100, buy 5 $20 lamps and have it all over your house, rather than one really nice one like this that is going to be in one place. What you obviously all know is that fluorescent light is not so great in terms of doing tasks. But many of people who are in the office, I've seen it, they've got their own little desk lamp that allows them to see better. So fluorescent lighting's got a place, but it's really helped people to get around, to illuminate space rather than to illuminate tasks, if that makes sense. Francis was telling me that glare often is a big problem with uveitis patients. Not surprised. There's there's a lot of ways you can deal with glare. One of them is really wide brimmed hats. Another is sun shields, and that you can get in certain places that wrap around. They wrap around even regular reading glasses. And I know of a company called Noir that has like 12 different shades of sun shields that go wrap around the face, your eyes. There are some that are very, very dark and some that are very light. So, but they're great because they cut glare, because they wrap right around. It's not just a pair of sunglasses. They wrap all the way down. You wear it on your ears. So, as I said, we're an occupational therapy practice. I'm going to blitz through this because I didn't. I should have taken the slide out, so I apologize. But this is who we are, real quick. But this is important because of intervention, we can really make a difference. You know, our work, and I'm not saying that we work with patients in their homes, as I said. So we develop what we call the essential skills scale. So this is a 4-point scale with 4 being the least, 1 being the best. And we do this when we do an evaluation of a patient, and we do this, we do an assessment at a discharge. And we're pretty proud of these numbers, you know. And we talked about falls before. If we can I'm not saying we can reduce falls, but we can reduce falls. I don't guarantee we can reduce falls, but if you teach the right strategies back to lighting and getting moving obstacles, etc., you know, that's 70% improvement. You know, it gets down to prepare a meal. That's 35.7%. That's down to, you know, eating and drinking neatly. I just had a patient yesterday. His wife actually said, you know, when he eats, unfortunately, it's a mess, and he doesn't know where things are. So I'm sure some of you have heard of the clock method. Yeah, so let's talk about eating for half a second. The clock method is where you've got a dinner plate, you've got a plate, and when whoever's laying down the plate, they say, hey, you know, the mashed potatoes are 12 o'clock, the chicken is 4 o'clock, the green beans are at 8 o'clock. So people can get a sense of the orientation of the plate. And plus, we're very big on contrast. So, you know, a white plate on a white tablecloth is not a good thing. You know, we say get a colored plate or get a colored tablecloth. And similarly, you know, glasses that are clear glass is a real problem because they're basically invisible to whole chunks of people. So again, get good contrasting colors that people use for their for drinking beverages. And you know, we can't guarantee you never spill again, but you know, we're pretty sure that you'll be spilling less. And it gets down to, you know, the ability to call 911 emergency contact. So you know, learning compensatory strategies can really make a difference for people in terms of a lot of things. It can help them everywhere from to becoming more independent. More independent, you know, goes back to maybe less falls, but also back to that being more feeling better about yourself and self-esteem. I mean, we're working with a patient now whose self-esteem is horrendous. I mean, all he's focusing on is everything he can't do. And so it's a real challenge for us to help him understand, let's start small. Let's think of little things that you can do with compensatory strategies allow you to be more successful. This is who we are. So if anybody want to write it down, I'm happy to answer questions offline. It would take me too long to do this, but there is, just visualize what I'm going to say to you now. You know, we work with patients who, they'd say to me, you know, every time I pour that cup of coffee, I make a mess. In fact, I'm gonna escape, get out of here, and I'm gonna go into my stop share, and I want to prove a point. There we go. And part of the reason is I have a beverage here. So all of you, this morning when you went ahead to pour something, most people, when they pour something, they pour it from an arc. I see a head bobbing, yes. Okay, you pour from an arc. And you can imagine how that easy it is to miss the glass. All right. So what we do, in fact, we say, no, put the edge of take the spout and put it on the edge of the glass. And when you're doing that, you've minimized missing the location. So that's one thing. Second thing is we say, you know what, we want our patients to pour. We want them to have their morning cup. I mean, I'm useless without my morning cup of coffee and reading the Globe. Useless. So the point is, we want them to do that. On the other hand, we want to make sure that they're going to be successful doing it. I wish I had the slide, but you can hopefully envision what I'm saying, that you pour from an arc into the glass doesn't work so well. And so in addition, have that cup be in like a little tray or even the sink. So if you miss, the spill's contained. And the implications, I think, are pretty significant. If every time I pour a cup of coffee and I make a mess, you can see why clinical depression is there. Who am I? I can't even pour myself a cup of coffee. So it really tears at people's self-esteem. So this is important. All these little strategies can really help people not only just be safer, but feel better about themselves. As it is, it's a challenge. It's a challenge because that not being able to drive is a huge thing. And I know some people can drive, I know other people can't drive, but you're totally beholden to other people to take you down to the pharmacy and down to the dry cleaners and whatever. And we New Englanders, we're kind of like independent stock, like I want to manage my own affairs. And if I have to depend on everybody for everything, it really, really, really tears at people's self-esteem, that loss of independence. Low vision specialist. And let's do, Francis, ask if anybody has seen a low vision specialist, if you could, please.
So if people want to put in the chat if they've seen low vision specialists. Jose says
Jose,
yes.
you did. That's great. Good. I bet you're not many.
At one point in time in my life.
I want to make a plug for low vision specialists. So I guess not many have seen the low vision specialist, Francis. Is that what to presume?
I guess so. No one else did. I've seen somebody. Oh, Alona said she did, and Eileen Harrington did too.
Good.
So
I want to make a plug.
And John Keller. We have a few.
All too often, doctors treat disease, ophthalmologists treat disease, and they don't think about functionality and the challenges that the patients are facing. And so there is a discipline out there called low vision specialists. I want to just make a plug for that. There is about 20, maybe 30 in the entire state. What they are is they're optometrists, so they're doctors of optometry, and they've been specifically trained to work with people who've lost some vision. And they're good to go to because they really understand the functional impact of low vision, and they can prescribe all kinds of devices, including, very high power spectacles. There's, the technology keeps moving. There's many of you may know about video magnification machines, but now they're down to where you can actually hold it in your hand, and it's like $450. And not only do you hold it in your hand, you move it over the text you want to see, but you can change. Remember I said earlier, black on yellow is a good combination, black on white on black. The electronics are really cool. It can do all kinds of really cool things. So sometimes that the handheld magnifier I showed earlier, again, we don't think people should just, if at all possible, go order online or go to the drugstore. I mean, when in fact these specially trained doctors can be so helpful. So what I would urge you to do is go back to your own ophthalmologist and say, do you know of a low vision specialist I could go to? There's no downside to it. There's absolutely no downside. Because maybe that doctor will be able to, prescribe a device that could really make a big, big difference. Going to CVS for magnifiers doesn't work so well. Not in this population. So,
Mr. Feldman,
I'm sorry, Francis?
Mr. Feldman, on that topic, could you explain, and I may sound ignorant, but I've been to low vision at Mass Eye and Ear. There's several people involved. I can't remember if they have an occupational therapist, but what would be the difference between the occupational therapist through your group or going to a low vision specialist?
Oh, that's a great question. And you're not ignorant at all. So thank you for the opportunity for me to describe it. A low vision specialist are a doctor of optometry, so they would be prescribing special devices. We're not doctors of optometry, we're occupational therapists. We are, I'm going to use that term again, we're totally driven by what can we do to increase your functionality? What can we do to teach you so that you're more able to do the tasks, the things that you want to do? So we work hand in hand with low vision specialists. You just heard me give a plug for low vision specialists a second ago, and it's important for a couple of reasons. One is these devices, I mean, I don't know if any of you was using 10 power magnification, but that's a big deal. That's a real challenge to use. If you're using spectacles, spectacles are hard to use, learn how to use, because our normal reading distance is about 12 inches, away from the face. And the higher the magnification, the closer the work has to be to your eyes, to the point of where, like in 10 power, it's literally like an inch away from one of the eyes. So we work with low vision specialists, and they will refer their patients to us. And one of the tasks that we do, besides the daily living skills, is help them learn how to use that device in their home setting as effectively as possible. So we think that we're partners of low vision specialists. And Francis, there was something important we talked about before, and then I'm happy to take the questions. That is, you told me that some people only have usable vision in one eye. And that happens. We run into that all the time. Or that the difference in vision, the acuity between the two eyes, is pretty significant. That if we humans, we use both eyes together for depth perception. So when one eye is weaker than the other, it really affects our ability for depth perception, and that manifests itself in a couple of ways. One of them is you reach for that glass, and it's not exactly where you think it is, right? And the other part of it is, stairs and curbs all of a sudden become a whole lot trickier and challenging. Because you're putting your foot out. Is my foot out? Did it go beyond the curb? Did it not get on the curb? And so, and so part of what we do is compensate. We can't totally overcome the depth perception challenges, but at least we make people aware of it, which is, being aware is important. I have a saying in life, it's important to know when you're not nuts. It's important to know when you're not nuts. And so I'm saying to you, yeah, you're not nuts if you only have usable vision in one eye and it's affecting your depth perception. It is. It's what happens.
Mr. Feldman, do you have resources for people for cars, for driving, depth perception and driving and parking?
There are
people
some
with
low vision specialists. They're
called
if field neglect, in other words, if let's say the left side of the field or the right side of the field is not has been lost, sometimes that's a neurological event. There's something called prism glasses. And it's very clever. Basically, it's mirrors that are force whatever image you're not able, let's say the right side, it forces it into your left side of viewing. And again, you don't get that at a drugstore. You have to go to a low vision specialist to do it. there's not, I don't know of many. I don't know of many, and certainly everybody knows that once you've been declared legally blind, you're not supposed to be driving anyhow. Day, night, doesn't matter. There are some driving teaching programs for people who are visually impaired. I can't think of one off the top of my head, but I have heard of them in the past. The best bet is, as I said, to go to a low vision specialist who might be able to prescribe something that can compensate.
Thank you. So I think we can open it up to the group for questions. If you want to raise your hand, Yasmin, if you can help me detect people, or you can put it in the chat.